Hey everybody, I am Dr. Gibbs. I am so sorry about yesterday. If you were here yesterday and you couldn't hear me, that is completely on me. I'm so sorry. So we're going to do take 2 on Graves' disease today, and hopefully everybody can hear me. And I'm really sorry about that. I did not have the sound right yesterday. Anyway, so today I want to talk about Graves' disease. And I am Dr. Dana Gibbs. I'm a thyroid and hormone expert in South Lake, Texas. And if you're listening to this and you're not a physician, please keep in mind that scientific proof is not nearly as black and white as people think. And in order to make treatment decisions for individual people, sometimes we have to consider evidence that's not nearly as absolute as we'd like. So this is not meant to be a medical advice, and you should consult your own physician for any medical issues or diagnoses that you may have. So last week we talked about one variety, the more common variety of autoimmune thyroiditis, which is Hashimoto's disease. And autoimmune thyroid disease is complicated. Autoimmune disease is complicated. They occur when your body erroneously makes antibodies that attack our body tissues or bind to our body tissues instead of to the disease causing agents that antibodies are supposed to attack, such as bacteria or viruses. And so today I want to talk about the second leading thyroid related autoimmune disease, which is Graves' disease. And Graves' disease is the leading cause of elevated thyroid function in people. So, what's going on in Graves' disease? Well, it is an autoimmune disease, and antibodies are made that fit the TSH receptor on the thyroid gland or in the thyroid gland, the TSH receptors, and stimulate them. So if you watch some of my earlier lives, you probably remember. So thyroid is a gland in your neck that makes thyroid hormones. T3 and T4 are the two main ones that drive our metabolism or increase our metabolism. And they do that in response to a brain chemical called TSH. That binds to the receptors called TSH receptors. Yeah, they were really original when they made these names. But anyway, so the thyroid hormone that's in our blood goes back to our brain, to our hypothalamus in particular, and tells the hypothalamus, hey, we have enough thyroid hormone right now. You don't need to make any more. So the hypothalamus signals your pituitary gland, and the pituitary gland slows down the production of TSH. TSH is the chemical that goes to your thyroid gland and says, okay, make more thyroid hormone, we need more. So when you have an antibody that triggers that TSH receptor in your thyroid gland, it does it without input from your brain in that hypothalamus pituitary axis. So your thyroid hormone blood tests get higher and higher. And your brain says, okay, we don't need any more. So the TSH number that comes from the pituitary goes down and down and down. And that's actually the first way that we know what's going on. So how you diagnose this is that your TSH will be low and your T3 and your T4 will be high, and reverse T3 that we've talked about before, reverse T3 gets high because it's trying to blunt the effect on your metabolism from too much thyroid hormone. That's kind of its purpose in life. So that actually gets very high as well, although most doctors don't actually measure that. But anyway, many people mistakenly get diagnosed with Graves' disease when they have this pattern of high T3, high T4, and low TSH, along with the symptoms of elevated thyroid levels. and they get mistakenly diagnosed with Graves' disease. But how do you know it's Graves' disease? Well, there are tests for that TSH receptor antibody, which can also be called thyroid stimulating immunoglobulin if you're going to order the test. But there are some other tests as well that kind of give you clues as to whether this is Graves' disease. So one of them is called a thyroid uptake scan, and that's where you take a dose of radioactive labeled iodine and then scan your body to see where that iodine goes. And if it's Graves' disease, the presence will be diffuse. It will go to your thyroid gland and it'll really light it up, but it'll be the entire thyroid gland. Whereas other kinds of thyroid diseases that cause high iodine uptake will actually be of the thyroid very frequently, or it'll be mottled, or it'll be irregular. Thyroid Graves' disease also shows a pretty characteristic result on a sonogram, which is first a ground glass opacity, which means that it's really diffusely uniform, and it shows ground glass, and it also shows if it's active, it'll show something called a thyroid inferno pattern or increased vascularity. Another finding that is specific to Graves' disease is something called thyroid eye disease or Graves' ophthalmopathy. And what this is it's due to the antibodies. Those antibodies to the TSH receptor actually go into your eye sockets and bind to the thyroid stimulating hormone receptors that are on fibroblasts, or a kind of cell that are mixed in with muscles. So in the extraocular muscles, there are these fibroblasts, and the antibody binds to the thyroid stimulating hormone receptor on those cells, along with a second hormone or chemical in your body called the insulin-like growth factor. That goes to an IGF receptor, IGFR. And those two then link up and they stimulate your immune system to cause inflammation in that area. So it's in the muscles of the eye called the extraocular muscles. It's the fatty tissue, the connective tissue inside your eye sockets get something called glycosaminoglycans, which are a polysaccharide, and they infiltrate the muscles and those surrounding tissue and cause them to bulk up. So if you look at an MRI, for example, their extraocular muscles will look really thick and fat. And what that does is it causes too much tissue inside your eye sockets and it pushes your eyeballs forward. So that's called exophthalmos. So it's bulging eyes or swelling around the eyes. And this can be really dangerous because eventually the person who has this can't close their eyes all the way and they may lose their vision. And of course, it's very noticeable and uncomfortable too. All right, but what are the other causes of Graves' disease? So the exact cause for most autoimmune disease is not really actually known, but some things that can move people towards Graves' disease would be genetic factors. First, a family history of autoimmune disease in general, and then second, a genetic history of having Graves' disease in your family. But then there are a lot of other causes. So history of exposure to high iodine containing medications or contrast agents, history of a recent viral infection or inflammation of the thyroid called thyroiditis, and then other environmental triggers besides iodine include smoking, high stress, other infections, so infections in the thyroid gland, I already mentioned that actually, sorry, trauma, including surgery or maybe being choked, labor, preeclampsia, And then there's some medications that can actually seem to trigger Graves' disease, such as aspirin overdoses, and something called checkpoint inhibitors, and then tyrosine kinase inhibitors. All right, so what other than that eye bulging are symptoms of Graves' disease? Well, most people don't start with the eye bulging. They start with the more common symptoms of hyperthyroidism, which are unexpected weight loss when you're not trying, heartbeat, maybe even palpitations, or irregular heartbeats, and then tremors. So they call it, instead of a slow tremor, it's a very fine, rapid tremor. Particularly when you're trying to do fine motor control skills, and then intolerance to heat, and sweating. And then there's another symptom combination called thyroid storm, and this is actually really, really dangerous. And what this is a very rapid heartbeat, irregular heartbeats. It can actually result in something called a dilated cardiomyopathy, which is heart damage, a new onset of confusion or delirium or psychosis, plus abnormal vital signs of fever, and that can be a really high temperature above 40 degrees, a patient who appears septic, without any noticeable focus of infection, high blood pressure, and then frequently jaundice is noted, which is yellowing of the whites of your eyes and your skin. And then I mentioned that severe agitation and confusion, and then eventually loss of consciousness. So these things are an emergency that is generally needed to be treated in ICU due to the high risk to the heart. And actually, when you start taking the medicine to control it, you can actually end up with cardiovascular collapse due to the treatments if they're not carefully administered. So how do they treat that? Well, you treat any Graves' disease initially with medications that slow your thyroid down, called anti-thyroid medicines, which there are two. Methimazole is one, and propylthiouracil is the other one, which suppress the gland. And then if you are an integrative doc like me, then you may want to do something called suppress and replace, because there's this concept that if there are less thyroid receptors expressed on the thyroid gland, then the impetus to your body to make more of that antibody will go down. And so that concept is called suppress and replace. And so what you do is you actually give higher doses of the anti-thyroid medicine, and then you give patients back thyroid hormones so that they have plenty of thyroid hormone to feel okay, but they don't have TSH receptors, and they don't need an elevation in TSH or even have a TSH. Anyway, so what are the chances that this will go away on its own? Well, it's pretty good. So remission in Graves' disease can happen in between 20 and 70% of people who have Graves' disease. That is seen spontaneously with just the suppression. And the odds are actually better in Europe, maybe 50 to 70% in Europe, whereas here they're like 20 to 50. And it's just my opinion. This is completely only my opinion, but I suspect that because Europe is more careful with their food supply, and they are more likely to not have toxins in their food, or to have pro-inflammatory foods, that may be one of the reasons why people's odds are better in Europe, but I have no proof of that. Anyway, for the Graves' ophthalmopathy, there are also now biologics. There is an FDA-approved biologic that can actually reduce the swelling, allow the eyes to regress back into the head. It's called teprotumumab. That's a real mouthful. There are other drugs that are being researched as at present, but really anything that you can do to reduce your stress, reduce your amount of inflammation are really advisable to do along with the treatment. Now, what if Graves' disease does not regress or go away on its own? Some people will choose to go ahead and have their thyroid either ablated or destroyed using radioactive iodine treatment, or have it removed by surgery. And there are pros and cons to both of those approaches, particularly if the medications to suppress the thyroid are not working well, or it doesn't go into remission, or it keeps coming and going and coming and going. Then people may decide to go for that, and that's an acceptable approach. However, it does not stop the ophthalmopathy from happening in all cases. It does remove the TSH receptors that are in the thyroid gland. It does not remove the TSH receptors in the other tissue, particularly in those fibroblasts that we were talking about that are inside your eye. Now, just one caveat and one word of caution is that other forms of thyroiditis, including Hashimoto's and infectious thyroiditis, can cause elevated thyroid levels. And sometimes what's happening is when the immune system in Hashimoto's disease is really tearing up your gland, it can release a lot of stored hormones, and the patient may feel and initially test as though they have Graves' disease. This is called Hashitoxicosis sometimes. And the initial treatment is the same, which is meds to slow down your heartbeat and to suppress the thyroid gland. So it is really, really important before you decide on radioactive iodine or removal of your thyroid gland to know which of those things you have. And those other tests that I mentioned above are the way to know. All right, that is it for now. I am Dana Gibbs, MD. I'm an integrative physician in North Texas, where I help people address their thyroid and other hormone imbalances. You can sign up for my newsletter at www.danagibbsmd to get valuable tips and notifications each time I do another one of these lives. Right now, they are scheduled every Tuesday at 6:30 Central Time. Also, if you're a thyroid or a chronic fatigue sufferer in North Texas and you want a caring doctor to help you finally resolve your symptoms, your exhaustion, your joint muscle aches, your poor sleep issues, come sign up now for a new patient evaluation with me at www.danagibbsmd.com. That's it for now, you guys. Thanks for watching. Bye-bye.